Well, hi, I'm going to talk about cardiac enzymes. My name is Maria Jose Gonzalez. A cardiac biomarker is a substance released into the bloodstream following damage of the heart muscle tissue. Cardiac markers are biomarkers measured to evaluate heart function. They are often discussed in the context of myocardial infarction, but other conditions can lead to an elevation in cardiac marker level. Most of the early markers identified were enzymes, and as a result, the term cardiac enzymes is sometimes used. However, not all the not all of the markers currently in use are enzymes. For example, in formal usage, troponin will not be listed as a cardiac enzyme. But I'm going to talk about troponins because they are a biomarker, one of the biomarker importance. Cardiac troponins have become the main biomarker utilized clinically for diagnosis of myocardial infarction. The cardiac troponins T, CTNT, and 1-CTNL are absent from adult skeletal muscle, which allows for high cardiac specificity. The cardiac specificity of troponin assays has led to increased utilization of this test clinically, and further research is currently being pursued to improve the sensitivity of these clinical assays. It is important to remember that although troponins are highly specific for myocardial injury, they are not specific for the cause of cardiac injury. Troponin is attached to the protein tropomyosin and within the groove between actin filaments in muscle tissue. In a relaxed muscle, tropomyosin blocks the attachment site for the myosin cross bridge, thus preventing contraction. When the muscle cell is stimulated to contract by an action potential, calcium channels open in the sarcoplasmic membrane and release calcium into the sarcoplasm. Some of this calcium attached to troponin, which causes it to change shape, exposing binding sites for myosin on the actin filaments. Troponin is found in both skeletal muscle and cardiac muscle, but the specific versions of troponin differ between types of muscle. Creatine kinase. Creatine kinase is an extracellular enzyme involved in the transfer of high-energy phosphate groups from ATP to creatine. The enzyme is dimer made up of either or B types of units. These subunits generate the isoenzymes predominant in brain. The CKMB cardiac enzyme is found in greater proportion in cardiac muscle, but accounts for only 14 to 42% of total cardiac muscle activity. CK levels become elevated within 4 to 8 hours after coronary artery occlusion, peak between 12 and 24 hours, and return to normal between 3 and 4 days. Historically, CKMB was utilized as the key diagnostic factor in assessment of a suspected ME, but troponin has become the new gold standard utilized clinically. This is largely due to the fact that 37 conditions other than myocardial infarction have been associated with elevated CKMB levels. Myoglobin. false positives are common with myoglobin because the myoglobin found in the myocardium is indistinguishable from that found in skeletal muscle. After AMI, serum myoglobin levels rise within 3 hours of symptoms and are elevated in 80 to 100% of patients at 6 to 8 hours, peak at 4 to 9 hours, and with normal kidney function return to baseline within 24 hours. False negatives may occur if the assay is done after myoglobin has been cleared from serum. Myoglobin is still a good marker if used to rapidly diagnose myocardial infarction soon after onset. Myoglobin is released from damaged muscle tissue, which has very high concentration of myoglobin. The released myoglobin is filtered by the kidneys but is toxic to the renal tubular epithelium and some may cause acute renal failure. Myoglobin is a sensitive marker for muscle injury, making it a potential marker for heart attack in patients with chest pain. However, elevated myoglobin has low specificity for acute myocardial infarction, and thus CKMB, CTNT, ECG, and clinical signs should be taken into account to make the diagnosis. Thank you so much, and they are the most important biomarkers about cardiovascular system. Thank you.